I want to talk about muscle diseases. Muscle diseases are very rare. Muscle diseases that are inflamed are called myopathies. A rheumatologist treats inflammatory myopathies. The muscle diseases are broken up into categories including the following. There is dermatomyositis, there's polymyositis, there's inclusion body myositis, there's immune-mediated necrotizing myopathy, and finally, there are the anti-synthetase syndromes defined by proximal muscle weakness with a synthetase antibody or interstitial lung disease with a synthetase antibody. Now, these conditions are rare. They're very, very rare. In fact, most would consider lupus rare, but a few percent of the population has lupus. This is something where there are 10 or 15 patients in the practice with it compared to 500 lupus patients. The anti-GL1 antibody makes 1/3 of the cases of anti-synthetase syndrome. The EJ, OJ, PL7, PL12 antibodies make up the other 2/3 of the cases. While there are small nuances in the different phenotypes of each of those 5 synthetase antibodies, it is becoming apparent to me that the disease is overlooked, underdiagnosed, and people are not looking for it. You can have an overlap. We have one patient right now with a PL7 positive antibody and rheumatoid arthritis. Being vigilant, I did a muscle biopsy and she has severe necrotizing myopathy. She's lucky because she had already been treated for rheumatoid arthritis on Remicade, and the Remicade is keeping her muscle disease under control in spite of Remicade not being the drug of choice, number one, for somebody with a new diagnosis of anti-synthetase syndrome. Today there was a case of anti-synthetase syndrome overlapping with dermatomyositis. What an interesting conundrum this is. So there's the overlap and there's more to this story. The patient came here and didn't feel well. The patient had fever, weight loss, weakness, generalized, and had an evaluation due to a rash. Blood testing was done. Their CPK was normal. They had definite weakness of the proximal muscles on physical exam. So an EMG was done. The EMG revealed myopathy. Following the EMG, a muscle biopsy was done. The muscle biopsy revealed features of dermatomyositis and anti-synthetase syndrome-related myopathy. Now, the CPK in this patient was normal. How on earth could the CPK be normal? Well, the opposite situation is clinical amyopathic dermatomyositis. What does this mean? Amyopathic means without muscle involvement. So amyopathic dermatomyositis means a patient has a classic dermatomyositis rash and a very high risk of cancer. However, they do not have muscle weakness. The opposite is so rare, but I must make this video just to tell you, you can have typically, and it will be typically dermatomyositis, you can have a raging case of dermatomyositis with a normal CPK. Normal CPK, aldolase being irrelevant, and urine myoglobin being irrelevant. I'll tell you why the others are irrelevant and when they should be used or shouldn't be used. So it's said that a person to get CPK in the blood must have muscle breakdown that enters the bloodstream. It is known and documented that dermatomyositis does not always do that. Therefore, people with dermatomyositis, no matter how bad their muscular disease is, may have a normal CPK. This may create problems treating them. However, it may just take a little bit longer, as you're normally following the CPK and you're waiting about a month after the CPK normalizes for the strength to come back. This is not new information, but if you're a patient, this is very valuable information. Myositis is generally not associated with muscle pain. It is associated with proximal muscle weakness. Okay, now, the patient who has the combination of the OJ antibody and the dermatomyositis rash and normal CPK has raging myopathy on biopsy. The patient is responding to a combination of prednisone, azathioprine, and rituximab. You might say, why rituximab so early? Well, with the synthetase syndrome and the possibility of rapidly progressive interstitial lung disease, I did not feel that using IVIG would be sufficient, and I did not feel Celsep, cyclosporin, or tacrolimus would be sufficient. Okay, next interesting fact that occurred in the last few days here at the Office of Arthritis and Rheumatology, Dr. Stephen Soloway and Associates. We had another outrageously interesting muscle case. Pardon me. All right, while I'm trying to think about what I forgot, the lesson here is that you can have severe myopathy with a normal CPK. And I did want to mention why the aldolase is irrelevant. First, there's only one condition ever documented that has an aldolase that is disproportionately higher than a CPK, and that would be eosinophilic myalgia syndrome caused by use of L-tryptophan for sleeping disorders. This is now banned in the United States. It's not used. There are no more cases of eosinophilic myalgia syndrome. So there's really no reason to order there's no reason to order an aldolase when the CPK gives you better information. The next thing would be a good situation to consider urine myoglobin. If you're treating an 80-year-old who weighs 80 pounds and they have a small muscle mass, and their muscles happen to be very inflamed, and they do have a normal CPK, such as 200, their baseline might be 20. Well, 200 may show up as normal, and 20 is their baseline. If you don't know the patient and you're not sure if 200 is an abnormality for them or not, you can check the urine myoglobin. If the urine myoglobin is astronomically high, then all their protein is being put into the urine. So I did want to mention this information as well. If I ever think about the other case or interesting facts that I wanted to tell you, just checking, we recently did have a case of synthetase syndrome with not only the PL7, but we had one recently with the OJ antibody. So these cases are being seen here probably 2 to 3 times a week, new cases with synthetase syndrome. Don't forget, you must look for overlap syndromes. You must viciously look for interstitial lung disease, skin changes, overlap with dermatomyositis, overlap with rheumatoid arthritis. Biopsies are not necessary to diagnose a straightforward case of dermatomyositis. However, I would argue that if you have overlap with a synthetase antibody positive and typical dermatomyositis skin lesions, you should get a muscle biopsy, even though you know they already have dermatomyositis. The vigilance for the synthetase syndrome and the possibility of the rapidly progressive interstitial lung disease, in my opinion, and this is not necessarily the opinion of other experts, I believe a biopsy is warranted. All right, thanks for listening. Tell me what topics you want. I'm a little bit more motivated to start making more videos, and I miss you, and have a nice night. Thank you.